Hello, this is Kim Jong-il. Today's topic is Premolar Extraction Guideline (PEG). Which teeth to extract is an important issue in orthodontic diagnosis. More specifically, it is about whether to extract the first premolar or the second premolar. Various factors are evaluated when deciding premolar extraction. In case of a Class II malocclusion with large overjet, factors such as overjet, canine key, and molar relationship are assessed, and many orthodontists focus on crowding and interincisal angle. However, mio-orthodontics encompasses combination factor, APDI, overjet, canine, and molar keys, POP, curve of Spee, crowding, and interincisal angle to devise the PEG index. Skeletal factor and combination factor are primarily concerned to decide whether to extract or not, but dental factors cannot be overlooked. Overjet, canine key, and molar key are the important dental factors. The treatment goal is to obtain a Class I canine key relation. Here is a full Class II with large overjet. In order to treat this, after the extraction of upper and lower first premolars, the upper canines should be maximally retracted without much molar movement. APDI is considered first for evaluating antero-posterior relationship, followed by overjet, canine key, and molar key. The treatment can be finished with mio in case of a half Class II canine key, but it should not be finished in case of a full Class II canine key. A full Class II canine key should be corrected to half Class II or Class I prior to finishing stage. Therefore, the positions of the upper and lower canines are very important in orthodontic diagnosis. Although maximum retraction of both the upper and lower dentition may be favorable, there is a clinical limitation in case of a large overjet. In order to obtain a Class I canine key, the upper first premolars are extracted. With non-extraction treatment in the lower arch, the treatment can be easily finished by maximum retraction of the upper canines and formation of proper overbite and overjet. However, if there is a lower anterior crowding, the upper incisors cannot be retracted much as they occlude with the lower incisors. In this case, the lower premolars should be extracted, and the lower second premolars are the preferred teeth to extract. After the lower incisors are retracted, the upper incisors can then be retracted. In some cases, the extraction of the lower second premolars can be problematic. It is difficult to close extraction space in adult patients with round faces low angle. Sometimes a lower incisor is inevitably extracted if there is a lower anterior crowding. If the crowding is severe in both the upper and lower arches, extraction can be decided by molar relationship. There is a severe crowding in the upper arch. The lower incisors are also crowded, but they are slightly lingually inclined. Let's discuss arch length discrepancy. When the discrepancy is greater than 15 millimeters, maximum anchorage is needed in order to fully retract the incisors after the extraction of the premolars, which provide about 15 millimeters of space. However, in moderate or minimum anchorage, there may be some space remaining in the posterior region after the anterior teeth are retracted to aesthetic position. If this space is closed by further retraction of the incisors, it is likely that they will be in an unaesthetic position. Interincisal angle is an important factor in orthodontics. If it is greater than 130 degrees, non-extraction treatment should be carried out if possible. If it is less than 110 degrees, there is a possibility of premolar extraction. However, in some cases, even though the interincisal angle is close to 130 degrees, the premolars have to be extracted because of severe crowding. In such cases, extraction of the second premolars would be preferable, especially in the lower arch, because the extraction of the lower first premolars will lead to further uprighting of the lower incisors and worsen the interincisal relationship angle. This patient has U1 to FH 106 degrees, IMPA 94 degrees, and a normal value of IIA 128 degrees. The upper incisors are lingually inclined, and the lower arch is U-shaped with anterior crowding. If the lower arch is extracted with non-extraction approach, the lower incisors will be proclined. But the patient's chief complaint is lip protrusion, and it is difficult to resolve this if teeth are aligned without extraction. Then what happens if the first premolars are extracted? The inclination of already uprighted upper incisors is likely to be worsened. Favorable profile can be achieved by extraction of the upper and lower second premolars in this patient. As you can see, the incisors are minimally moved while the molars are moved forward by a large amount. In normal POP, either the lower first or second premolars can be extracted without much problem. However, in steep POP, is it easier to extract the lower first premolars and upright the second premolars, first molars, and second molars to flatten POP? Or is it easier to extract the lower second premolars and upright the first molars and second molars? It is much easier with the extraction of lower second premolars. If the mesially angulated lower molars are not uprighted, the upper incisors have to be more extruded, leading to an unaesthetic profile. Therefore, by flattening steep POP through uprighting, the upper incisors can be located at an aesthetic position. These are the factors considered in PEG. According to PEG, in Class 1, either the first or second premolars can be extracted. In severe Class 2, only the upper premolars can be extracted. In intermediate cases, the upper first premolars and the lower second premolars can be extracted. This is a 26-year-old female patient with anterior crowding and lip protrusion. Since CF is 157, non-extraction treatment should be carried out if possible, but it is not possible because of lip protrusion. Skeletal relationship is normal. Class 1 with APDI 81 and 2 mm of overjet. Canine and molar keys are Class 1. Curve of SPE is -1, POP is flat, crowding is slight, and IIA is less than 120 degrees. Therefore, the upper and lower first premolars can be extracted in this patient. Favorable profile and occlusal relationship can be achieved by the extraction of upper and lower first premolars. The incisors are retracted to aesthetic position, and the molars are slightly moved forward as well. As a result, the chin is protruded a little, leading to a more favorable profile. Keep in mind that the posterior teeth are moved forward, and if not, the incisors are likely to be more lingually inclined. This is a 20-year-old female patient with anterior crowding and lip protrusion. The patient had difficulty with closing lips due to protrusion. Both the upper and lower arches are U-shaped, and there is anterior crowding in the upper arch. Lip protrusion is not too severe. Let's look at the PEG-CF is normal with 153. Overjet is 4 millimeters, APDI is 77, canine and molar keys are half class 2, curve of SPI is -2, POP is flat with 17 degrees, and interincisal angle is small with 114 degrees. Which extraction is better for this patient? Extraction of the upper first premolars and the lower second premolars is advisable. Favorable occlusion and aesthetics can be achieved with this extraction option. The upper and lower incisors are retracted aesthetic positions, and the molars are slightly moved forward. The lower molars are uprighted as well. This is a 23-year-old female patient with chief complaints of anterior crowding, mobility of the upper right first premolar, and TMD on left TMJ. The lips are slightly protruded, and there is an anterior crowding in the upper arch. Canine key is class 2, and there is no crowding in the lower arch. This patient has normal values of ODI, APDI, and CF. CF is sufficient with 155, so non-extraction treatment should be carried out if possible. Overjet is 5 millimeters, APDI is 78, canine and molar keys are full class 2, and POP is steep. Which is a good extraction choice? Only upper premolar extraction would be a good choice. Favorable aesthetics, canine key, and occlusal relationship can be obtained by the extraction of only upper first premolars. The lower molars are uprighted because teeth were not extracted, and the upper incisors were retracted and the upper molars were moved forward to close the extraction space in the upper arch. This is a 21-year-old female patient with chief complaints of anterior crowding and lip protrusion. ODI, APDI, and CF are all normal. Overjet is 2 millimeters, APDI is 81, canine and molar keys are class 1. Curve of SPI is -2, POP is somewhat steep with 14 degrees, and interincisal angle is 128 degrees. Since interincisal angle is 128 degrees, it is advisable to extract the second premolars in both the upper and lower arches. Favorable aesthetics and occlusal relationship can be achieved by the extraction of upper and lower second premolars. The upper and lower incisors are slightly retracted, and the molars are moved forward. Despite the molar forward movement, the lower molars are uprighted. As a result, the chin is slightly protruded, leading to a more favorable profile. As you can see, PEG can be an easy guideline for extraction choice in orthodontic diagnosis. Thank you for watching.